here from southeastern Wisconsin in the United States. I want to thank you so much for the opportunity to present today on drug delivery and kind of where we're at in this space. I do speak and consult for a number of the companies in the glaucoma and anterior segment space, including some of the products you're going to hear about today. It's an exciting time, as you all know, with SLT and laser trabeculoplasty, MIGS, and now drug delivery, kind of rounding out our toolbox with the hopes of dealing with these issues of compliance. I mean, compliance really does suck. How to keep people on drops for long term, despite issues of cost, side effects, forgetfulness, ocular surface disease, all which have the potential to lead to poor compliance and therefore potentially for progression. Now, we have a lot of products that are being investigated right now. Some are intracameral dissolvable biodegradable implants, some are non-dissolvable or biodegradable, and some are external as well, which we'll talk about. I'm going to spend a lot of time talking about more bimatoprost sustained release, also known as Durysta, which is approved in the United States last year in June. Was our first commercial patient that we implanted. It was part of the phase 2 and phase 3 trials as well. Now, it's a bimatoprost, one drop, which is 10 micrograms of bimatoprost in a vehicle that biodegrades into lactic acid and glycolic acid. Now, releases bimatoprost for 4 months, but the longevity effect can be longer. In fact, the phase 2 trials showed us 25% of patients had 2 years of efficacy with just one implant as well. On the bottom right is what it looks like on the gonioscopic view after being implanted. Again, you want to have open angle patients, Schaefer grade 3 or more, and you want to have patients who have healthier corneas, no Fuchs dystrophy or endothelial cell issues as well. Now, the actual insertion, I never use the word injection to patients. I say the insertion is very benign for the patient. They think of it like an IOP check, really. I do it at the slit lamp without a speculum or second instrument, and I insert it anterior to the limbal vessels. That's a 28 gauge needle. Press the button. It sinks to the bottom into the inferior angle. Now, I have a kind of a dual press technique here, slow motion. I press it one time halfway, let the implant come in out halfway, and then further depress it again to kind of push it out. The reason why is a little air bubble you see there. If you just press it with one motion, especially if you press it slowly, what happens is that implant can get stuck to the needle tip, and what can happen is it comes back towards you. I'll show you a video of that. But once it's in the anterior chamber, anywhere in the anterior chamber, it eventually finds its way into the inferior angle because of gravity. And it kind of just sits there and has a tacky material, so it allows it to sit in the inferior angle, and it really doesn't move around or float around much. It just kind of stays where it sits. What can happen, though, sometimes it's kind of fun, some troubleshooting scenarios. You press the button, and that air bubble gets attached to the implant. It goes whoop, way up. I call it Durysta rising. You can say, where'd it go? Well, it's in the superior angle. If this happens, not a problem. Give it some time. You can either tap on it with a Q-tip or just give it some time. The air bubble will separate and the implant will sink to the bottom because, again, of gravity. As you see here, after about a minute or so, it came down to the bottom and it's nicely in position as well. What can also happen is if you're inserting it here, anterior to the limbal vessels, two bevel lengths in, you press the button, but the implant is stuck to the needle tip. And as you come back out, it stays with you and it wants to get attracted back to the needle track. Now, if this happens again, give it time. It'll eventually sink to the bottom. You see those little air bubbles like I was talking to you about. Now, if this doesn't really separate on its own, you can take a Q-tip as you see here. I'm just going to tap on it a couple of times, and it may or may not separate. May give it another extra few minutes. It'll eventually kind of separate. But if you have ADD like me and you don't want to wait for it, what you can do is you can take an AC probe here, just push it away from the needle track. Again, this is a 28 gauge needle track. We're just going to go right through that, push it away a couple of times. Now, a lot of times we'll just separate, but this air bubble is still there. But what I did do is I was able to separate the air bubble from the needle tract itself. And so now that it's separated from it, the air bubble is just going to eventually go whoop and bring that Durysta up again to the superior angle. And again, after about a minute or two, finds its way down as well. So again, these are simple troubleshooting scenarios, nothing that's very difficult, just to be aware of what can happen when you're inserting these products as well. Now, what's nice about this product, having 24-hour release, preservative-free bimatoprost in the eye, is we're getting into the target tissues. On the bottom left, compared to topical medications, more of the bimatoprost is in the aqueous humor and ciliary body, versus on the right here, less of it's in the other tissues that we don't want to be in, like the conjunctiva, the eyelid, and the periocular fat pads. Now, we're also seeing from histopathology slides is we're seeing a separation or enlargement of the spaces in the anterior ciliary body and in the conventional outflow pathway. And these could be the reasons why we're seeing longevity of effect. Again, expression of MMP compared to placebo, significant expression of MMP and decreased expression of TIMS, the tissue inhibitor of MMP. Could this be the reason why we're seeing longevity and kind of a modification or disease modification happening? Now, we don't know yet. More studies are needed. But that's what's exciting about this. Again, 36% of patients had 1 year of efficacy with one implant in the phase 2 trials. 26% of patients had 2 years of efficacy without rescue therapy. In the phase 3 trials, after 3 injections, again, every 4 months, after the third injection, 86% of patients did not need any rescue therapy after 1 year. Now, the key is it gives you what a PGA gives you, about a 33% reduction of IOP, 5 to 8 millimeters of mercury reduction based upon the phase 3 trials at 12 weeks out. But the key is also safety. We didn't see hyperemia issues, the periocular changes in fat pad, iris pigmentation changes like we see typically with topical bimatoprost. Now you see here 27% hyperemia. These are all from the actual insertion in the studies. After the insertion, because of betadine scrubs and proparacaine and holding the eye still, in the studies, patients did report hyperemia and subconjunctival hemorrhage and some issues right after the procedure. But after that, we did not see any issues there. There were a few patients on the bottom here. You see iritis that has some chronic inflammation. In fact, one implant was removed. Otherwise, very, very well tolerated medication. Again, one of the reasons why I think this is a big benefit for patients. Cell loss was not a big issue. With one implant, we saw 0.9% of patients having any type of cell loss between 10 and 20% of the endothelium. In the phase 3 trials, about 20 patients or 5.4% of patients had cell loss between 10 and 20%. Again, not a huge amount. We do a lot worse with glaucoma surgeries, but this is something that I think the FDA still wants to watch for and also learn how often do we really need to implant these devices as well. So it has the approval for one implantation in the United States. So I tell patients like this patient here, look, let's give you a holiday. Let's give you a drop holiday because it's such a benign procedure from the patient's perspective. Let's see if I can give you 4, 6, 8, 1 year of efficacy without having to take drops. And if you have to go back to drops, we can. Like this patient who is non-compliant, fluctuating, had ocular surface disease, SLT in the past, has some GCC loss. RNFL is not too bad. But in here, you can see slowly progressing. The key to this patient's pre-parametric. So I don't want to wait till this patient has significant field loss before I'm more aggressive. Let's deal with this now. So this is a patient, we put Durysta in both eyes. Here's a real life pictures of this patient. Saw him back not too long ago, about 9 months after the implantation. Still has efficacy, still in the middle teens without needing topical PGA therapy as well. In our studies that we looked at clinically non-published, the first 40 patients that had at least 6 months of time, 89% of patients still were not needing rescue therapy as well. So exciting times. But remember, it's approved for only one administration. You want to have good aseptic conditions, good head stabilization, and anybody for me who has some compliance issues is a good candidate. Cost, side effects, forgetfulness, hyperemia. That's the kind of patient where we can give them a period of time off of medications as well. Now, for the sake of time, I'm just going to move on to some of the new products that are being investigated. Ocular Therapeutix has their Travoprost implant, which is very similar to that of Durysta, like I showed you, inserted very similarly at just anterior to limbal vessels with a 28 gauge needle as well. Now, again, they're a little bit behind in terms of their studies. They're in about the phase 2 trials right now and starting their phase 3 soon, but fantastic results. You see a good efficacy over 6 months here, about 10 mils of mercury as well, looking at very good outcomes there and very similar in terms of its type of product and how it looks in the inferior angle with gonioscopic view as well. Envisia has their product, which is a Travoprost, also dissolvable implant. This is their print technology. They have a larger and a smaller implant that they're also investigating. And Glaukos has their iDose. I was also involved with this study here. They just finished our phase 3 enrollment. And again, this is a canister that's implanted into the nasal angle, similar to that like an iStent that has a proprietary oil, Travoprost oil, that releases over a couple of years actually, that we're finding very good results as well. There are phase 2 studies that have been released show us pretty good, darn good efficacy. There's a fast and a slow eluting version, and you find in the fast eluting version about 8 millimeters of mercury of reduction of IOP at around 24 months as well. So fantastic results there. There's a punctal-plug delivery device by Body Therapeutics called the Evolute, which has a non-dissolvable implant that goes into the canalicular system. Then they can then change the punctal part of it by putting a dissolvable piece that can release medicine over time as well. So they're seeing very good retention in the 90s in terms of retention over a 1 year period of time. And they're having good results. This is a very short 7-day study here showing their newer version, though, giving us about 7 to 8 millimeters mercury reduction as well. And then Amorphix has their technology, which goes underneath the eyelid and is allowing us to release a PGA over a few weeks to a few months, which is very straightforward in terms of how it's applied and how it's released. And supposedly it's very comfortable for the patient as well. And then lastly, the external ring by bimatoprost ring, which is also by Allergan, which was, again, it started a few years ago, can kind of halted the study. Now, recently, the phase 3 trials are starting again. Again, a bimatoprost ring that also is external, which I think would also help for some of those surgeons who don't want to implant something intracamerally as well. So I think it's an exciting time. We have a lot of options. I don't think, to me, it's a stepwise fashion. I think drug delivery and drops are there to help you throughout the entire paradigm, whether it's early, advanced, disease, pre and post MIGS, or even traditional incisional surgeries. We have a lot of options now. We're really hoping to address compliance issues and not wait until they're more advanced, where the need pressures down that sub 10 range as well. Exciting times. Love to answer questions. Thank you so much for the opportunity, and take care.